All right, hello, welcome to chapter 2. This is basic physical activity and exercise recommendations for persons with chronic conditions. So now we're finally going to get into what these recommendations are, and we're going to reference it throughout the rest of the semester. So why don't we get started? All right, so here's a little bit of background for the CDD4 recommendation. So again, if you missed it in chapter 1, anytime I mention CDD4, that's our textbook. And it was basically written by a panel of experts in this field who deal with chronic conditions and the research with it. So they all developed it together. And it's a slightly more conservative version than the ACSM guidelines from the ninth edition. So ACSM has been developing guidelines kind of for a general population, similar to what we talked about in chapter 1. But CDD4 wanted to mainly focus on individuals who have multiple comorbidities that complicate the standard guidelines for exercise. However, the big point here, and you're going to hear me say this many times throughout this semester and today especially, is use your judgment. So just because the guideline says someone should be able to do something doesn't mean that that specific individual can, right? So you have to really use your judgment to see how every individual ranks given their chronic conditions. So first, let's define a couple of terms that get used interchangeably. Physical activity versus exercise. Are they technically the same thing? Not really. So typically they just get used as the same word, and most people, anyone you meet, and us too in the exercise science field, usually just use them interchangeably. But the World Health Organization definition of physical activity is bodily movement produced by skeletal muscles that requires energy expenditure. So therefore, the term exercise is a form of physical activity, but more specifically, exercise training is regular physical activity. So the difference is it's planned, structured, and repetitive physical activity for the purpose of developing physical fitness. All right, so just clarifying a couple of terms here. Now, I am including this here to talk about the intensity of physical activity and breathing. So we will refer to this a little bit later, but I want to show it now just so we can kind of talk about it before we get there. So um, the main intensity categories that are listed are light, moderate, vigorous, and high. You could see the MET equivalents there, but I mean, let's be honest, you're not going to measure METs with your clients, right? Or your patients. So you're probably gonna have to find a different way to measure what kind of intensity they're doing for the level of exercise. So, um, the best way to do this is to do a talk test, and it's extremely easy, and you don't even have to tell them that you're doing this test, right? So, the idea is that up to moderate intensity, they can pass the talk test, meaning when you're talking to them, they can respond without, breathing too hard, without breathing too deeply. Vigorous exercise is when they can't pass the talk test. You should do this on yourself if you've never done it before. Um, like just go out for a run or something, and try to hum a song or try to speak. And if you feel like you have to keep taking pauses to take breaths, then you're probably in the vigorous zone. In the high zone, you can't talk. So, this is a pretty good way to assess someone's intensity for a given form of exercise. And we'll talk more about this in a couple of slides. Now here we have the 10-point RPE scale, which I will again talk a little bit later. The textbook just refers to it many times throughout the chapter. So this scale is the 0 to 10 point rating of perceived exertion. I guarantee all of you have seen some form of this before because you're all in your masters, right? So this scale has been validated for use in pulmonary disease populations. And that's why the book recommends it. It's a pretty good one to use for chronic conditions, but we'll talk about this again soon. One thing I want to note here, though, in relation to the METs that we talked about, is that 5 hard should be relatively close to the ventilatory threshold. So that's just, you know, a way to interpret the scale. Okay, so leisure time physical activity before we get into the actual guidelines. So, this is physical activity that's achieved during leisure time or occupationally. So, leisure is not related to your work. So, maybe going on a walk after work, running in the mornings, so on and so forth. And occupational, some people still have jobs that allow them to get some physical activity in. Maybe it's walking, maybe it's actual physical labor, whatever it may be. However, there are a lot more sedentary jobs in modern society nowadays, so it's actually a lot more difficult for people to meet certain guidelines for physical activity because of this reason. And here I refer back to the example of parking the car far away. So I talked about this in chapter 1, but a pretty solid recommendation you can give people to try and increase their physical activity is park the car far away when you're going to work so that you'll have a 10-minute brisk walk to go to work, and then take a 10-minute walk during your lunch break, and then you'll have to walk 10 more minutes back to your car. That's 30 minutes per day. So, just some things to keep in mind right before we jump into these recommendations. All right, so how do we develop exercise guidelines? What is the history of how we're getting the guidelines that we're going to look at? So, the US Department of Health and Human Services conducted a search in 2008, looking at all of the different guidelines, and they determined that the most common guidelines that were out there that promoted health were the following. So, minimum of 150 minutes of moderate physical activity, or alternatively, 75 minutes of vigorous physical activity. Two or more days of muscle strengthening for all major muscle groups, and then balance improvement for individuals at risk for falls. Now, this looks like a lot, but following that study, um, the EU physical activity guidelines were recommended, and they're extremely similar. And here's just a list of a bunch of other guidelines for from leading organizations for activity. So we're not going to go individually box by box here. And it kind of looks like a puzzle of, what's different and what isn't. Like, can you spot the differences between all the different guidelines from these organizations? A lot of them are very, very similar because they're mainly aimed toward general populations, right? So people who don't have chronic conditions or don't need accommodations to perform exercise. The one difference you will see is this Swedish one right over here. So this box here says yes. These guidelines are designed specifically for chronic disease patients. But all the other ones, again, there's a lot of similarities. So let's jump into the actual guidelines we're going to use for the rest of the semester. But I want to first lay out what these guidelines are not. So these guidelines don't give disease-specific recommendations. That sounds a little off to hear, first of all, right? Because I thought we're going to get into guidelines for specific conditions, right? Well, there are a couple of reasons why the authors of these guidelines didn't want to do it that way. So, first off, and I mean, just to be realistic, thousands of chronic conditions exist, so it's not feasible to write guidelines for each one. Also, most recommendations are similar for most conditions, so they don't differ that much from each other to warrant completely different guidelines. And then complexities and nuances are matters of clinical judgment for safety's sake. This is where I'm going to harp again, use your judgment. It's a very big part of working with these populations. And the main concern of CDD4 is a loss of independent living, and that's why light physical activity is the focus. So, what are they? Finally, we get to what these guidelines are. So, I'd recommend write this down and keep it handy somewhere where you can easily refer to it in the following weeks because a majority of the lecture is going to be, well, here are the guidelines. Here are the things that change depending on what kind of chronic condition someone has. So, You're going to see it's really similar to everything else that we just saw in that big table of all the leading organizations. 150 minutes of preferably moderate intensity physical activity, but if this is not possible or it's too difficult, then light intensity is okay as well. At least 2 days per week of flexibility and muscle strengthening activities that should minimally involve chair, sit, and reach stretches. At least 8 consecutive sit to stand exercises, at least 10 step ups leading with each foot, and at least 8 consecutive arm curls with a minimum of 2 kilograms in each hand, but 4 kilograms is recommended. They also say that individuals at risk for falls should be evaluated for causes of falls. Now, they should be evaluated because not every single um, uh, cause for a fall is treatable by exercise. So there may be things that exercise just won't help with. But if the diagnosis of the causes suggests that exercise training can reduce the likelihood of a fall, then activities to improve balance should be incorporated under the supervision of an exercise therapist trained in fall prevention. So again, use your judgment. If it's something that exercise can help with, then it should be incorporated. Now, here's a topic that we absolutely have to talk about, risks and adverse events. Um, these can never be completely eliminated, and you guys will definitely come to learn that if you have to write an IRB proposal, if you're doing a project for your master's. But there are two main concerns. So there's activity dependent risks. So any type of risk that's possible due to the nature of activity. And then the disease dependent risks. So things that are very specific to the condition, the pathophysiology. So the big question with this is, can physical activity expose the possibility of a disease dependent risk? So this topic always kind of gets to me. And honestly, I'm sure you guys have probably had experiences like this too. Maybe someone in your family or, your cousins or, family, friends, they know that you're in the exercise field. And it just, I don't know, you hear the opinions of people sometimes, and it really makes you think, wow, we need to do a little bit better about educating people. Um, People really cling to anecdotes of things that happen. Like when I went home for Christmas break, for example, and we met with some family friends. And they were, I mentioned I'm running every day, because it's good for me and it's good for the heart, right? Like I think we would all agree, right, in this classroom. Um, and then the family friend told me, "Oh, well, someone I know who runs every day just had a heart attack. You should be careful. Like, you shouldn't do it too much." Okay. I mean, there's so many things there. Like, was it because of running? Was it because there's a disease that they didn't have, like a chronic condition they didn't have, or didn't know that they had? Like, there's so many things. I don't think running is the reason. Unfortunately, the guy had a heart attack, right? Or you'll hear a lot of things. Sometimes I've heard it from doctors too. Like you shouldn't do certain types of strength training or weight training. I mean, again, I think you guys probably have more stories than I do from your experiences, right? The public holds a very interesting view of risks associated with physical activity, but this is a question that should be asked for disease-dependent risks. Now, risks are typically dependent on the intensity of exercise, so it's usually pretty, I mean, I don't want to say easy, but it is feasible to try and prevent it, right? So if someone's doing vigorous or high intensity physical activity, then we have to refer to guidelines on testing and prescription. And we actually will talk about testing in a couple of slides. Um, However, most individuals with chronic conditions can safely participate in moderate intensity physical activity. And if there is for any reason concern about this, then that person should either undergo diagnostic exercise testing or be referred to a supervised exercise program, or do both. An example of this can be people performing exercise in a physical therapy clinic, because there's people who are trained there just in case anything happens, even though, again, things should not happen. They should be monitoring it. You could do talk tests. You can, they can have blood pressure monitors if need be. Um, and yeah, so again, it's typically very safe. And on that note, what about light intensity physical activity? So these are mostly anecdotal cases that support this concern, especially sudden death or myocardial infarction. So again, I think people just kind of latch on to anecdotal cases, like a story that happened, like someone they knew that was doing this and then XYZ happened, like they dropped dead or something. It's very unfortunate when it happens. However, research doesn't back this as a legitimate concern. Um, Light intensity activities are also ubiquitous in everyday life. They're everywhere. Like anything you do is light intensity activity, right? Going upstairs, walking to class, walking to your car, walking your dog. It's general everyday life activities. And if someone is so unstable that these activities of daily living threaten injury or death, then the book's recommendations don't apply automatically. The individual can't maintain their independence and they belong in a hospital or a nursing home. So again, the CDD4 recommendations are to maintain people's independence, right? To allow them to have their autonomy in life. So if they already don't have that, then these recommendations are a bar above what they're capable of. And unfortunately, as the book notes, most people prematurely end up in hospitals or nursing homes because no one recommended them to do light intensity physical activity. Goes back to that downward spiral we talked about in chapter one, right? So again, you should be careful. This isn't to say that nothing ever happens. Of course, we know that things happen. Adverse events happen all the time. And any of you who've done any form of coaching or training or if you've coached teams like sports teams, then this stuff happens. Like it happened when I was teaching soccer and they were adverse events that wasn't normal, right? So this is just a little note for you guys. And good luck just dispelling false ideas about what exercise can do for people, right? Okay, so how do you prescribe exercise? So we have two methods that we'll talk about. The first one you've definitely seen before, the FIT method. It stands for frequency, intensity, time, and type. So I'm not going to delve too much specifically into, what each one is because I almost guarantee that all of you have seen this before. Um, but but one thing I will mention is for intensity. So how hard someone exercises. We'll talk about perceived exertion in a couple of slides, but the main concern with this, and we'll talk about it extensively with each condition we look at, is that there are various things that can alter someone's response to exercise. So, beta blockers, so if they're taking beta blockers as medication, then that impacts the way that their heart works, and you can't exercise at the same level as someone who isn't taking beta blockers, right? Prosthetic users also have increased economy when trying to do exercise compared to other people, so that's another thing to watch out for that we'll talk about. And also just altered heart rates. There are a lot of conditions that alter the heart rate response to exercise. So, yeah, intensity is definitely something that you have to keep your eye on when working with these populations. Now, the other method, which is really interesting, and maybe some of you more on that med school track would maybe be more interested in this one, is basically prescribing exercise the same way that you would prescribe a drug. So every drug has an indication or a diagnosis that makes the drug appropriate. So the indication is a specific chronic condition to be treated with exercise. So it's basically the same way as prescribing it with the FIT method, but you would just word it differently as if it's a drug. So for hypertension, for type 2 diabetes, for like whatever you want to insert there, do XYZ. Frequency of exercise, intensity, and time. That's no different from the FIT model. Just some people might be more comfortable prescribing it this way. Maybe some clients or patients would be more receptive to this method. Okay, so let's talk about intensity a little bit more. So there are a couple ways to judge exercise intensity. The graphic I showed earlier had METs as an option, right? But recording that is difficult. You need more equipment to do that. So we usually want something that's a lot easier and less expensive, right? So heart rate and RPE have been the most common methods to do this. Now, I'm sure a lot of you know this because a lot of you are from sports backgrounds or just in general, you're active people. Heart rate is historically the traditional measure. It's the most objective. I know I use that to judge my exercise intensity, and I'm sure you guys do too. However, we're going to have to change it up a little bit for these populations because chronic conditions and medications can alter heart rate response. Every chapter we go through, we will talk about drugs that certain people might be on if they have a certain chronic condition, and we'll talk about how that changes their heart rate response to exercise. So, the book's recommendation, remember, they're all experts that have dealt with these topics for most of their lives. They say that RPE is the preferred method. And the best way to calibrate this is to use the talk test for each individual. So, um, I mean, we know individuals, right? Like some people don't exactly give the correct rating of perceived exertion. Like sometimes they say it's too hard and they're still talking to you. Like, so um yeah, using the talk test is a pretty good way to find out exactly where they're at on the intensity scale. Now, why don't we talk about what scale to use? So I showed you the 0 to 10 scale, but some of you may also be familiar with the 6 to 20 scale, the Borg scale. Um, so typically in when we do research, when we're working with athletic populations or in general, like a healthy population, we tend to use the 6 to 20 scale, but the 0 to 10 scale is based on a nonlinear relationship between exertion and ventilation. And for most people who are not in our field, 0 to 10 is a more intuitive range, right? 0, no work, 10, extremely difficult. 6 to 20 is based on a linear relationship between exertion and heart rate. And this exercise response is in relation to healthy young college students, where their resting heart rate is 60 and their maximum is 200. So, if you're working with a population or a person that doesn't have anything that affects their heart rate response to exercise, then 6 to 20 is actually a very appropriate scale. And it may, because it's a linear relationship, it may be easier to use. And once you describe it to them as, oh, it's supposed to correlate with your heart rate, that might actually be more intuitive for them and for you. However, if you're dealing with populations that don't exactly have the same heart rate response, then 0 to 10 might be better. But ultimately, it's up to you. And it's probably best to ask the patient as well what they would prefer. But the 0 to 10 scale was developed for people with chronic conditions. So just keep that in mind when deciding what scale to use. Now, exercise testing. So we talked about this in the risks section, but you can't just send everyone for an exercise test, right? That costs money. A lot of insurance plans won't cover it for absolutely no reason. Like there should be a reason to do it. So you should ask yourself a couple of questions. Is an exercise test necessary for exercise management and physical activity? You have to consider the prudence of the testing and an appropriate battery of tests for a client. So you're not going to make them do a VO2 max test, right? You should look at specifically what would work for them, what would be the most useful information to get from the test. The book describes a short physical performance battery, and I believe this is available outside of the book as well, so I'm not going to go over what it is, but it could be a useful alternative for some people. But related to exercise testing, there are certain reasons why you shouldn't test someone. So the guidelines give these specific individual attributes to not perform an exercise test: extreme deconditioning, orthopedic limitations, left ventricular dysfunction that limits exertion by shortness of breath, known coronary anatomy, recent successful revascularization, recent uncomplicated or stable myocardial infarction, and a recent pharmacologic stress test. Now, why these, right? Why these specific reasons? Well, deconditioning and the other limitations listed there, will likely prevent the individual from achieving 85% of their age predicted max heart rate. So for these tests, you have to reach a certain point, right? Even if it's not a max test, you should still reach the submax bar that's listed for it. And if they don't, then you're just going to get a non-diagnostic study as a result. Basically, we did this test for no reason. The patient is unhappy for no reason. We didn't learn anything. Or the other reason is that the cardiac diagnosis is already known, so you don't have to do a test to determine something that you already know. So the recommended strategy is if you're not going to test for people, especially because of those reasons, then start low, progress slowly, and be alert for symptoms. This is talking about starting with low intensities. Don't ramp it up insanely fast, be very slow, and be alert for symptoms. And I say this again, use your judgment. Your judgment is it could save people. So just always be aware of that when working with anyone, really, not just chronic disease populations. Okay. The CDD4 recommendations do give an evaluation that you can do if you elect to not do an actual test. So at a minimum, patients should be able to do these. 6 or 8 meter gait, greater than zero point 0.6 meters per second, 8 sit to stand repetitions in 30 seconds, 8 arm curls with 4 kilogram mass, ascending a flight of 10 steps in under 30 seconds, and chair sit and reach to the toes on both sides. So these are just the minimum requirements that they say they should be able to do. But again, use your judgment. That's the most important thing. Okay, minimum recommendations for activity when a test is not available. So again, aerobic training, this is the key. You have to start slow, go slow, don't progress too quickly, and be alert for any symptoms. For strength training, 2 sets of 30 seconds of sit to stand repetitions, 2 sets of 8 arm curls with 4 kilogram mass, 10 step ups 2 times, and chair sit and reach 2 times holding for 30 seconds. Okay, what about high intensity interval training? What is there to say about that? So we've talked about low intensity a lot, moderate intensity. It's a little bit of vigorous, right? What about HIIT training, right? And I spelled it wrong. I'll fix that when I upload this. So this is actually like the basis of the walk jog programs. Wow, I don't know what was wrong with me when I was doing these slides, but walk jog programs are based on HIIT training. And actually, childhood play is based on HIIT training because they don't know how to pace themselves. So they go all out and then they have to take a break. Think tag in the safe zones. We had safe zones, I don't know. But yeah, that's just typical HIIT training. Um, and the best way to define it is it's an exercise session that consists of alternating periods of high intensity and low intensity exertion, or it could be periods of rest, if not low intensity. And it's been documented to be an effective alternative to produce greater changes in physiological performance and health-related factors. So again, a lot of you come from athletic backgrounds. You know about this. Anytime you're doing sprint training, it's typically high intensity interval training, right? Um, so we know about this, and there's even specific types of HIIT training, like fartlek training, if you've heard of that, speed play in Swedish. So we know it in this realm, but what do we do with chronic condition patients, especially given the talk we just had about risks and adverse events that might happen due to intensity? Well, the good thing about HIIT training is that you can tailor what that training can look like. So the volume of each interval, so the duration and the intensity of it, the length of recovery between the exercise interval in minutes, the number of exercise intervals performed, they can all be altered and played around with, depending on what the person's comfortable with. So, again, use your judgment. It's recommended to keep it constant intensity and constant duration for these chronic populations to see their individual tolerance. And if they've never done HIIT training before, for them to understand how it actually works and how it feels. So, yeah, don't go playing around with it too much. Find a good constant intensity for them and then adjust. If they're doing great, then increase it, right? Okay, and then last thing to leave you guys with, and I don't have too many comments for this because I don't have these certifications. Maybe some of you do. Um, these are a couple of personnel certifications that you can get. So exercises medicine level 1, registered clinical exercise physiologist, certified clinical exercise specialist, certified health and fitness specialist, certified personal trainer, and certified cancer exercise trainer. So if you are one of these, or if you want to get these certifications, you most certainly will work with everything we've talked about so far, um, with your clients, with your patients, right? So, these are just a couple of notes. Again, definitely keep those guidelines somewhere close by. Maybe we'll repeat it so much this semester that you'll just intuitively remember 150 minutes, 2+ days of strength training. But yeah, keep it close by that when we talk about the different conditions, you'll know what exactly we're going to change for each population. All right, and that is what I've got for chapter 2. I'm also gonna provide a quick video to show current trends of people who meet these guidelines. Um, and yeah, but I'll do that in a separate video. All right, have a good one.